Morning, everybody. Medical oncologist always last. Huh? So, yeah, right. We're used to that. Not the more important part. Thank you to the organizers. Stephen, it's a privilege to be here. Saw an old friend, Joe Herman, today. How about that? I have the task of discussing what we can offer to patients who either present with de novo metastatic disease, which is about 50% of the cases, or patients who have recurred after the multimodality approaches that you just heard about, which I'll call recurrent metastatic disease. And how do I control the slides? Right here? So, thank you. I have no disclosures that are relevant to this program, but there are some listed in the handout. The agenda for today, therefore, in the next 10 to 12 minutes, a one-slide overview of the issue we face. I'll go through, and again, one slide, a lot of data about conventional treatment, or shall I say conventional cytotoxic chemotherapy treatment for advanced esophagogastric cancer. I'll start then with the negative. Targeted therapies, the IBs, which are small molecules, and the ABs, which are antibodies, and which of those don't work in this setting, and then we'll finish off with positives. Item 4 would be targeted therapies that do work based on level 1 evidence, and then item number 5, of course, would be everybody's favorite immunotherapy, at least it's mine. So esophagogastric cancer is somewhat common in the United States, but very common worldwide. I'd say about 50% of the patients present with metastatic disease, which, as you heard, is incurable, at least prior to the setting of immunotherapy. Those that are treated for cure with multimodality care, I would say about, 70% of those also recur. So we're faced with an issue that needs a fair amount of attention. Also, as you can see worldwide, actually, gastroesophageal cancer is the third most common cause of cancer mortality. It's something that we can forget from our perspective here. So the last 30 years or so have led to this one slide. So that was a lot of time in one slide, which summarizes the doublet and triplet chemotherapy approaches for advanced recurrent or metastatic adenocarcinoma of the esophagogastric site. Needless to say that the oldies are still the goodies. Platinum and fluoropyrimidines are still the most commonly used. The modern version of that is Folfox, 5-FU, and oxaliplatin. A lot of discussion about adding a third drug to platinum fluoropyrimidines, but really it just increases toxicity. Adriamycin, for example, or taxanes. Triplets are really more toxic, but really, other than improving response rate, do not change survival. So the next step then is, as we're always striving to do, is to make things better. A lot of effort, I'll summarize, about ABs and IBs added to cytotoxic chemotherapy. Let's talk about what doesn't work. So the first target, naturally, is because one of the initial ABs was against the epidermal growth factor receptor, HER1. Panitumumab, cetuximab, the most common. These were added to cytotoxic chemotherapy. Again, platinum fluoropyrimidine-based regimens. You can see two large randomized trials for first-line treatment of this disease. One trial, the REAL-3 trial, used EOX, Exus for Xeloda. Notice that does have epirubicin. It's a triplet, which has fallen out of favor. Plus or minus panitumumab, that was a negative trial. The second of a number was the EXPAND trial, which tested cetuximab plus capecitabine and cisplatin, also a negative trial. So it's safe to say that cetuximab and panitumumab are no longer of interest in the advanced setting. What about another critical pathway, angiogenesis? So vascular endothelial growth factor pathway, a receptor pathway. It makes sense because if you add the the paradigm drug Avastin in the setting of lung and colon cancer, you do provide a survival benefit. So Manish Shah and his colleagues at Memorial designed a study called Avagast, which used bevacizumab in the setting of a baseline Xeloda cisplatin, and it was a randomized study, plus or minus bevacizumab, and this was in the first-line recurrent or metastatic setting. The patients completed 6 cycles of 2 drugs and then continued on maintenance until either toxicity, the patient changed their mind, the doctor changed her mind, or progression. Primary outcome, again, gold standard overall survival. Left the survival curves at home, but if you look at the bottom row, that's the comparison for median overall survival. And although there is a 2-month difference, it did not reach statistical significance. So we do not use bevacizumab with chemotherapy in the first-line setting. So let's get positive. What does work? Well, there's another member. There's 4 members of the human epidermal growth factor receptor family, right? HER1 is EGF receptor. We talked about that being not useful as a target. The second, which is a very popular target, in particular in breast cancer, is the HER2 pathway. So let's talk about the use of trastuzumab, which is otherwise known as Herceptin, in this disease. There are some pluses and minuses about the TOGA trial. It was first line. Survival was the endpoint, which is, again, the gold standard. Issue is, on a negative perspective, you had to screen positive for HER2, and only about 20% of the patients could be selected based on this predictive marker. The positive is you have a predictive marker, which until this trial was done did not exist. So patients who screen positive for HER2 overexpression were randomized to fluoropyrimidine cis, not oxalic cis, which we really don't use, plus or minus trastuzumab. And as you know, the survival curves separate early, and the separation persists. And the hazard ratio, there's a 26% reduction in the risk of death for the patients with overexpressed HER2 who get chemo plus trastuzumab. So this, sort of like the cross trial for locally advanced disease, is the standard of care if you overexpress the marker in the first-line setting for advanced or metastatic esophagogastric adenocarcinoma. What else works? Well, surprise, surprise, now, it's confusing to me as well, we're back to the VEGF receptor pathway. Didn't work in first line when you targeted the ligand, but it does work in the second line if you target the receptor with ramucirumab. Second line, so patients progressed after first line cytotoxic chemo, they were randomized to either Taxol or paclitaxel, alone, or plus ramucirumab. And the curve's not as impressive as the TOGA trial, I would argue, but again, the hazard ratio does not cross 1, so this is a significant outcome. Second line Taxol plus ramucirumab is a standard of care. Positives, negatives. Well, I went negatives to positives, sorry. So of course, as a medical oncologist, I'll go back to the negatives before I move to immunotherapy. So this slide is other ABS and IBS, mixed and matched in various ways with cytotoxic chemotherapy. Lapatinib is a dual HER1, HER2 tyrosine kinase inhibitor, which does not work in either the first or the second line. TDM1 is a version of trastuzumab, which has DM1. It's a microtubule inhibitor. In second line, added to Taxol, Gatsby study negative. We've tried targets to the HGFC MET. Rituximab was too toxic, so that study was stopped early. Everolimus, which is an mTOR inhibitor in second line, also a negative trial. So we were stuck, I guess our patients, shall I say, were stuck until, 2 years ago, maybe 3, when immunotherapy, and I mean the kind of immunotherapy that we learned about yesterday during the plenary session, immune checkpoint inhibitors, became available. In this case, I'm going to talk about PDL1 and PDL2, not CTLA4. What you see here in a busy slide just summarizes that in esophagogastric cancer, both of these ligands are overexpressed. This was the strongest, I would say, preclinical argument to look at the use of these inhibitors in esophagogastric cancer. The inhibitor, in this case, is pembrolizumab. It's an AB, so it's an antibody. It's made against PDL, the ligand, pardon me, so it binds to the ligand so that you don't have a checkpoint between the activated T cells and the tumor. And based on the preclinical overexpression, Keynote 012 was designed. It's actually a bucket trial that had several different tumor types. I'm extracting here on my slide the data that relates to esophagogastric cancer. I'll point out that this is recurrent metastatic disease. Many patients had multiple lines of prior therapy, so these were pretty refractory patients. And by the way, we only have a standard of care up to second line. After that, nothing. The patients had to have a greater than or equal to 1% overexpression of the PDL1 in their tumor, so this was a selection criteria. I can't say it's a predictive marker, but it's a selection for this trial. And they couldn't be on steroids or other autoimmune, have autoimmune diseases be on steroids or immunosuppressants. Single arm, really looking for safety. They looked at a total of, they had 39 patients, if I recall. 36 of them were by central assessment evaluable for response, and you can see that by central review, the overall response rate was 22%. Although there were no complete responders, there were 8 partial responders, pretty impressive. And 5 patients had stable disease, and stable disease means living longer, so that's a victory as well. The waterfall plot suggests, just in a more visual graphic manner, patients with stable disease and PRs on the right side. And this is called a spider plot that shows the patients who responded had a decent duration of response, some patients extending out to, and that's in weeks on the x-axis, over to about 30, 40, 48 months is the extreme. So in a heavily pretreated population of patients with esophagogastric cancer, immunotherapy with pembrolizumab was intriguing. 2 more slides to stay on time. Does this pan out in a randomized study? The answer is investigated in a trial that was presented at GI ASCO this year, called the ONO-4538 trial. Uses a different checkpoint inhibitor, nivolumab, kind of a similar mechanism of action, versus placebo in patients with refractory esophagogastric cancer, prior treatment with greater than or equal to 2 regimens. So again, pretty heavily pretreated patient population. Usually the survival with these patients is months, even with best available therapy. Randomized to nivolumab versus placebo / best supportive care, and again, the primary outcome was overall survival. This data is pretty good. You can see a couple of things. Number one, the hazard ratio of 0.63 for nivolumab versus best supportive care. Number 2, you can see that the survival curve, and I'll finish off with a bit of hope for the nivolumab arm, which is in blue, seems to flatten out at around 1.5 years at around 20%. So this is what you'll find out as you see more and more the tail of the curve for checkpoint inhibitor therapy. It's possible. In fact, it's definite in melanoma that you could possibly cure patients with advanced esophagogastric adenocarcinoma with immune checkpoint inhibitor therapy. Lots of work to do for our patients. We want to keep them alive longer, if not cure them, maintain, if not improve their quality of life. And to do that, we have trials and research and lots to do. So thanks very much.